Okay, next we're going to look at drug absorption. Really, this is the first part of pharmacokinetics, the first of the 4 parts that we're going to cover. Of course, drug absorption concerns the processes of entry of a drug into the systemic circulation from its site of administration. Of course, movement into the blood is going to involve various factors such as drug permeation, lipid solubility, for example, a concentration gradient, exactly those points that we've covered so far. Now notice this, intravascular administration, IV, does not involve absorption. There is no loss of drug, and we'll talk about bioavailability, but for now, you should remember that the bioavailability of an IV administered drug is 100%. Okay? Importantly, does not involve absorption. There's kind of a trick question out there that basically asks you this. It says, what is the fastest route of absorption? And if you read this too quickly, you automatically fall for the trap and you pick IV. But not if you remember that IV does not involve absorption. What is the fastest route of absorption? That, of course, would be inhalation. Drugs move very rapidly into the lungs, into the alveoli, into the capillaries, in large surface area there, very rapid route. But importantly, when you think about the concept of absorption, it involves moving from its site of administration into the blood. Okay? And in the case of IV, you're actually injecting the drug directly into the bloodstream, so there is no movement from one compartment into another like there is, for example, with inhalation. Lots of ways to give drugs. So besides IV, lots of extravascular routes. And of course, if you give a drug extravascular, there is a great chance that less than 100% of your dose will reach the systemic circulation. And the term that we use here is bioavailability. Okay? If you interpret that term, basically it tells you how much of the drug is biologically available, or maybe another way to think about that is how much of your dose gets into the blood. Okay? How much of a given dose of drug actually gets into the blood, and that is the bioavailability of the drug. And sometimes that is a high number, sometimes it's a very low number, and that really will depend on how you decide to administer that drug in the future. Let's look at this particular curve. It'll allow us to set up some other concepts here. Plasma concentration versus time. When you think about this particular graph, there are a few terms here like lag time and onset of activity and duration that you need to be comfortable with. First thing is, when you look at the shape of this curve, can you recognize that this curve must be showing you some extravascular route? How do you know it's extravascular? Well, there's a couple of hints here. First of all, you're basically starting down here at a plasma level of 0, and you're increasing over time. In other words, the process of absorption is going on. The fact that absorption is going on means it's not IV. So it must be an extravascular route that's shown here. So let's start here. Basically at time 0, when you administer a drug, and you can imagine taking a drug orally. You take the drug orally, it's going to go down into your stomach, it's going to sit there for a certain period of time before any of those drug molecules actually move into the plasma. That's what we call the lag time. It's the time from first administration to when the first molecules appear in the blood. That is the lag time. Now, don't misunderstand. Just because you start to get drug into the blood does not mean that the drug automatically starts to work. You have to wait for the plasma levels to rise in the blood until you reach a very important point called the minimum effective concentration, or the MEC. The minimum effective concentration is where you're first seeing the pharmacologic effect of the drug. That is when the drug is first having its actions in the body. So when we go to our terminology here, from time 0 to the MEC, that is the onset of activity. Notice that it includes the lag time in that period there. Now, once a drug crosses the MEC, continues to rise in the plasma, it's still working, of course, it's going to reach a peak, it's going to take a certain amount of time to get there. When it reaches that peak, of course, once you're at the top, no place to go but down, so you start to decline. As the plasma levels decrease, you're going to come to a point where you cross the MEC once again. And of course, once you cross it and are down below it, this is all part of your process of elimination. But once you cross that MEC, you have really defined now the point called the duration of action. It's from where you first cross the MEC and really the period of time where you stay above the MEC. So from when you first cross to when you cross it again in the process of elimination. So duration of action. Can you influence drug absorption? Can you change the slope of this curve? And of course the answer to that is absolutely. One of the ways that people can commonly do that is to take antacids, for example. Antacids are going to raise the pH of the stomach, and that's going to decrease absorption, you should be able to predict, of weak acids. Okay? But increasing the pH of the stomach might actually increase the absorption of weak base drugs. And of course, you can change the elimination curve as well. You may not want to, but you could see a decline in renal function. And if that happens, you could actually see that the duration of action of a drug could be extended because of decreased renal elimination. Next, we're going to look at the concept of bioavailability. We've mentioned this once before, but when you think about bioavailability, it really relates to the area under the curve for some orally administered dose to the area under the curve for an IV administered dose. Notice that IV really is our standard here, our reference for this. Why? Because when you take a drug IV, its bioavailability is 100%. So really what we're doing in this comparison is we're trying to see if the route that we've chosen, for example oral, has the same bioavailability as the standard here, which is IV. So that's what the diagram is showing here. So this is an IV administered drug. Notice the exponential decrease over time in plasma concentration. And then here's the orally administered dose, increasing, reaching a peak, and then falling away over time. So really when you compare, you'll notice that there's an overlapping region for these two areas under the curve, and that's what's shown right here. But in order to effectively compare, you're basically asking this question: does this shaded region equal this shaded region? Or at least does this region here come close to an IV administered dose? And you can't predict that with certainty by just simply looking at the graph, but just visually you would say that those are pretty close, indicating that your orally administered dose is pretty close to your IV. In other words, it's pretty close to 100%. Now let me reassure you that you won't be asked to calculate bioavailabilities on your exam. However, you will need to understand a couple of things. And first of all, it's that we use the letter F to stand for bioavailability. And why F? Well, it's F for fraction of the dose. The fraction of the dose that reaches the systemic circulation. That's what really defines our bioavailability. And of course, if this number is less than 100%, you can imagine that you're going to have to modify your dosing equations. And you'll see that we have to do that in things like a maintenance dose or a loading dose calculation. One of the things that greatly influences the bioavailability of a drug is the first pass effect. Okay? And the first pass effect, of course, refers to the fact that when you take a drug orally, it goes directly into the portal circulation and is initially certainly sent to the liver. Okay? For some drugs, that effect of the liver, that very rapid metabolism, will dramatically reduce their bioavailability. And that's what we call the first pass effect. And kind of a way to think about this is that when you take a drug orally, the liver is going to get the first opportunity to do something to that drug. And that could be to significantly metabolize it and lower its plasma levels. And so when you look at the visual that's shown here, again, by mouth, the drug goes into the stomach, makes its way into the portal circulation, it gets churned around in the liver, and whatever makes it out the other side, that really is our bioavailability. And that could be all of the dose originally, or that could be a very small amount of the dose originally. Two examples here. The first one is lidocaine. Now, if you were to take lidocaine orally, what's going to happen is that it's going to go through this process, and when it gets to the liver, its metabolism is going to be so extensive that the amount of drug that comes out on the other side into the systemic circulation is going to be very, very low. Okay? So lidocaine is not very effective at all by the oral route. Therefore, IV is preferred to make sure we have the bioavailability for the drug to work. A second example, nitroglycerin. Of course, when you think about nitroglycerin, you could be thinking about treating an acute angina attack. And the way that we take nitroglycerin in that case is sublingual. Advantage of the sublingual route, when you put the drug under your tongue, you get a very rapid absorption with very little first pass metabolism. So sublingual is actually a way to avoid some of the first pass effects. Clearly injectable routes, IV and IM, are ways to avoid first pass as well, but sublingual does a pretty good job of avoiding first pass metabolism, and that leads to a pretty rapid onset of action for nitroglycerin.